Now I'm going to talk about the modern updates on what else can we do. I didn't go into the antiarrhythmic agents. Now I'm going into the rhythm control. Who are the people who are candidates for Afib ablation? Atrial fibrillation ablation is a procedure where we can just go find the circuits in the heart which are misfiring, and we can fix that circuits to keep you in normal rhythm. So atrial fibrillation, when it starts from the left atrium of your heart. So the left upper chamber of your heart, this is the left upper chamber, that's where the atrial fibrillation starts. This is the right upper chamber, this is the left upper chamber, right lower, and the left lower. This is where the point of interest is. This is where the atrial fibrillation starts from. So like atrial fibrillation, you need a trigger. Just like you have to light a fire, you need a trigger, which is the pulmonary veins. See this right here? This is the pulmonary vein. They bring the fresh blood from the lungs. These are the veins where the atrial fibrillation starts. Once it starts here, it trickles down, and then you got this sustainer, which is the left upper chamber is enlarged and some scar tissue in it, and it keeps the AFib keep on going there. So you need a fire. You need to start with something, and then you need a trigger, you also need a sustainer. So you got a fire, and then you need some wood to keep it going, and that's what happens. People stay in AFib, and then the heart keeps on going. So it's like an AFib. Once it starts, it just spreads all over. It just spreads all over your heart, and then it just takes over your rhythm. So this is the catheter-based percutaneous ablation these days we do. We can just go through the groin, just like a minimally invasive surgery, basically get to the access to the left atrium and the pulmonary veins. We call it transseptal catheterization. We go to the right upper chamber, and I'll show you the slide. We take a needle, cross over to the left side, and then we find these triggers, and we cauterize these triggers, and that puts you back in your rhythm. This is the localization of vein. We can do that under the fluoroscopy, and then we use the electroanatomical, we call the 3D mapping we use. We create a map of your left upper chamber trying to find these spots, and then we isolate these pulmonary veins. Isolation of pulmonary veins means we put like a little cigarette burns all around the veins, block the atrial fibrillation from coming out. We don't block any blood flow. We just block the abnormal electrical rhythms to come out of that from the veins. That keeps you in rhythm, and I'll show you the success rate in these cases. So this is how we do the procedure. It's done in the hospital. It takes about a couple hours to do that. You go home the next day or same day. Sometime if I do that in the morning, we go from the groin right here. We walk up all the way to here, to the right chamber. And there's a curtain between the right and the left chamber right here. We take a needle, we go through the left side, and these are the pulmonary veins. So this is where we work on all around. There's 4 pulmonary veins, left upper, left lower, and then there's 2 on the right side. This is a 3-dimensional map of the left atrium. This is where your atrial fibrillation starts. Like I said, there's 4 pulmonary veins. 2 on the left side, 2 on the right side. And this is what each spot what you see, this marker, is the ablation spot we do. So basically, we put electrical burns like this. So a normal rhythm cannot get out of this thing. And that keeps you in sinus rhythm. This does not damage the heart. It's very superficial burns. This does not block the blood flow. It just blocks the abnormal electrical impulses to come out so people don't go into atrial fibrillation. These days, we're using a lot of what we call the cryoablation as well. The one I showed you, that is the heat. We call the radio frequency. These days, we are doing a lot what we call the cryoablation, which is like a freeze. Instead of burning with heat, we freeze it with liquid nitrogen. This is the difference in when we ablate. This is the burn with the heat. This is the burn with the freeze. It's just a 3-4 millimeter burn deep. It's just like a superficial cigarette burn. That's all it is. But you can see the difference in that stuff. This is sort of like a cryoballoon we use, we call it. This is the thing we use to freeze. This contains liquid nitrogen. This is a double balloon, one on the outside, one on the inside, and the liquid nitrogen is in the middle, and it freezes all around, and I'll show you So this is how we do that, freeze. We go to the left chamber, we identify your veins, we put it here, and we freeze all around like this. What that does, it just with a single burn, it can cover the whole vein. It's a newer technology we've been using, and it cuts down a procedure time for you, anesthesia time for you, recovery for you, and gets a very good results. Question is when to consider the ablation. So in people who want to try the medication first, we try the medication. There's different medications we use. We use flecainide, propafenone, amiodarone, Multac. We use the sotalol, ticosine. So sometimes people have side effects. They don't want to take the medication. In that case, if they can't tolerate the medication or the antiarrhythmic therapy is not effective, in that case, we consider ablation. People with very symptomatic AFib, who gets very, very short of breath, very symptomatic. People with as a first-line therapy who say, I don't want to take the pill, I'd rather get an ablation done. In that cases, we go as well. In other whose ablation may be first-line strategy, patient with very symptomatic who refuses like antiarrhythmic drug, young patients. In that case, is actually instead of giving them the medication, because every medication has their own side effect. We call them poison, pick your poison. None of the medication is safe. They all have a side effects. So say they want to go for ablation, like I said, the youngest I've done is on 21-year-old, and patient with significant side effects from medication, like heart rate gets too slow, because all of these will slow down the heart rate. In that cases, instead of giving them pacemaker, we try to take them off the medication and use this drug. So who does the best? People with paroxysmal AFib. Paroxysmal AFib is their atrial fibrillation comes and goes. You have it today, you don't have it tomorrow. 6 months later, you have it for a few days, then it's not there anymore. Those are the people who are going to do the best. The success rate goes significantly better, and I'm talking about cure. I'm not talking about just making them feel better. Younger people, less than 70 years old, they will do very well. Minimal structural heart disease, who don't have a significant valve issue or left atrium is not severely dilated, those people will do very well. Able to tolerate the procedure and follow-ups, those people will do well. So the results, the success rate. So everybody asks you, what is the success rate in these cases? Is it worthwhile to do this procedure? Single procedure, 60 to 80% success rate. And the range of 60 to 80% is, it depends on what your age is, what your left upper chamber size is, how long you have the AFib. If you've got atrial fibrillation that comes and goes, you're younger, the left upper chamber is normal, your success rate could be as high as 80% chances that your atrial fibrillation will not come back. It's done, it's cured, will be gone. We take away all the medications at that point within 3 to 6 months. Multiple procedures, sometimes we have to do 10 to 15%. We may have to go back and do the procedure we call a second procedure. That improves your success rate to almost 80 to 90%. That if we do the first one, doesn't work as much, 6 months later we go back and do the second one, it improves your success to 80 to 90%. Somebody who has this AFib for persistent, like more than 3 years, significant large left atrium, in that case ablation may or may not be very successful. Best success with paroxysmal, healthy heart, least success with chronic disease and diseased left atrium. That's why somebody's with atrial fibrillation, we want to see them right away, or right away means we want to see them sooner. Don't wait for 5 years to come to the electrophysiologist. See them sooner. The sooner you see them, better the chances that we can put you back in.